Nafanya presentation, nitaomba nifunge hiyo mlango. Nitaweka video yangu on na ita quick.
Good evening, everyone. My name is Peter Ugeto from Kenya Medical Association. Thank you for taking time to join us this evening for this really enlightening webinar on management of neuropathic pain. We are happy to partner with Universal Corporation Limited to bring you this, and all right, welcome. I'm going to pass this now to our moderator, Dr. Eliash Don, to take up. Eliash.
All right. Thanks, Peter. Thanks, everybody, for finding time to be here this evening. It's a pleasure and a privilege to at least meet you virtually. And we hope for a very insightful discussion in the next few hours, one or so. So we are still engaging in the chat section. Please tell us your name. Of course, we can see it. Tell us where you're joining us from, and feel free to engage in the chat section should you have any question for the speaker or in line with our topic. Please feel very free to ask in the chat section, and we'll be able to respond to the ones we'll be able to find time to respond to. Thanks. We have people joining from Harare, we have Samburu, we have Bungoma, Nairobi, Kenya. Keep joining, keep letting us know where you're joining from. We have Nairobi, Busia, that's Evans Agwanda. Keep joining, and we are grateful to have you. My name is Dr. Don. I'm your moderator for this evening. I'm joining from Nairobi, Kenya. So first, I want to introduce our speaker. Our topic is management of neuropathic pain. It's a very exciting topic, and we're excited to be gathered here as a team of healthcare professionals to learn, relearn, and learn, and just get ready to give the best to our patients as it were. So thank you for finding time to be here. So I'll introduce our speaker, after which, I'll ask her to proceed. But before that, imagine, and as you picture this, that you get to somebody you know, a friend you've known for quite some time, and you reach out to shake their hand, and instead of feeling their skin, you feel a sudden jolt, as if a spark of electricity is shooting through your arm. Now imagine that spark you feel when you shake their hands, that spark does not fade. That spark lingers, it burns, it tingles. This is what many of our patients, many of our friends, relatives with neuropathic pain live through every single day. Pain that feels real and raw. Pain that even when nothing is happening, it still persists. Pain that seems, always present when everything else seems to be okay. So today, it's a privilege and an honor to host one of the leading, neurologists in the country to just take us through how we can make it better for our patients, make it better for our friends, our relatives, our colleagues who are going through this nightmare of neuropathic pain. We're going to explore why the nervous system sometimes rewrites the rules of sensation and how we can help patients navigate that invisible storm. So that is what we're going to do. Our speaker is Dr. Judith Kwasa. I'm a personal beneficiary from her wisdom, having been her student at some point, and it's a privilege and an honor to welcome her. She's a lecturer at the University of Nairobi for over 14 years now. That tells you we're not very old. And it's our privilege to host her as our speaker. She's a consultant physician and neurologist who's also running a private practice in Nairobi as well. So she's going to tell us anything else that I might have missed about her, and then we'll delve straight into the discussion. So feel free to engage us on what you'll want us to respond to, and we'll keep you posted as we proceed. Karibu, Daktari.
Thank you very much, Dr. John, for the kind introduction today. As you rightfully said, neuropathic pain is one of those major issues. And initially I was thinking, I was actually telling you just before we started that I don't imagine many people will join this webinar, but I was pleasantly surprised. And I guess I should have been able to think through it and say, yes, pain, and especially neuropathic pain, is actually such a prominent symptom. And we face a lot of difficulty trying to manage it and trying to give our people, our patients, a sense of peace and a sense of resolution of their pain, which oftentimes might not be 100%, but our aim is to just sort of try and put us in a place where we can feel a bit more confident about what we're doing and be a little more empathetic with what they're going through. So thank you so much.
Thank you.
All right. So without further ado, I am going to do two things. I'm going to be trying to share my screen, and likewise, I will, if you allow me, I will switch off my video for a couple of reasons. I want to save on my chargeable light. Excuse me for that. Sorry.
That's fine.
Okay, let's go back here. All right, I want to save on my chargeable lamp so that when we're doing the Q&As, we're not talking to a black box. And hopefully you will not mind that. So I'm switching off my video, no offense. Right, so my slides can be seen. I'm in slideshow.
Sure.
Okay, perfect. Thank you so much. Sorry, just trying to move a few things around here and there. Excellent. So in the next, hopefully, half an hour to 45 minutes, we want to go through the approach to the management of neuropathic pain. Now, I won't spend too much time on maybe a lot of things that you might have in mind, mostly because I'm trying to give you an overview, and I might not go to the depths that you're interested in certain things. And if I don't, please feel free to ask these questions so that we can individually address them. The outline of my talk will be to highlight something about pain pathways. So this will allow us to understand why we approach pain in this way, and then talk about a few individual pain syndromes, and lastly, to give a summary. So, by way of pain pathways, it's important for us to understand pain pathways because when we classify pain, it helps us understand what sort of pain we're dealing with and how best to approach it. I'm sure all of you who are practitioners have gone through, especially when you're dealing with people with long-term pain. As you can see, the two main areas of pain would be acute pain or chronic pain. And especially when you're dealing with patients with long-term pain and you put them on what would be an ideal drug for long-term pain, say a tricyclic antidepressant, a lot of them may or may not tell you that they stop them because you're trying to treat them for depression, okay? And they're not depressed, they're not crazy. But that's the thing. And so when we understand the classification of pain, it helps you better illustrate to the patient why this is important. So today we're going to be talking about this area on the right side of your screen, which is chronic pain. As you can see, pain can be acute, traumatic, and that's rather easy to deal with because it's very severe. If it's somatic, it's usually quite easy to deal with. If it's visceral, a little more difficult, but the beauty is it's quite responsive to lots of drugs. But when we have chronic pain, which is pain that's lasted more than 2 weeks, that's where we start having problems. And this can either be pain that's either malignant or non-malignant. Now, today I'm not trying to bite off more than I can chew. I'm really not dealing with cancer pain at all. I'm dealing with non-malignant pain or pain that is not arising from cancer. I think the management of cancer pain requires a whole different talk. And in this, we can either have it coming from muscles or from nerves. And I'm going to specifically be talking about neuropathic pain. So this helps us also direct our questions because I know a lot of us also deal with cancer patients, but I will not be focusing a lot on that. And we do borrow a little bit from neuropathic pain, but really I think that's a different topic. So let's think about how we manage or how we come across chronic pain. Now there are different pain mechanisms, of which some of them are peripheral, some of them are central. And when we talk about peripheral, we're talking about our perception of pain. And what that means is your pain is arising peripherally from, either from your pain receptors that are peripheral. So maybe you touched something hot on the stove and then you felt the pain. So that perception is a peripheral perception. Or your pain could be arising centrally. So say you've had a stroke that has affected, say, your right side. So apart from giving you a right-sided weakness, if it was on the left side of the brain and giving you problems with the language, if it's in an area of the brain that modulates pain, say around the basal ganglia, you might have a central origin pain. And these are patients who, apart from the weakness, also get this really strong, persistent pain. Now, sometimes the nature of the pain might not be much different. And they might all feel like a deep burning pain, but sometimes peripheral pains can also be less aching or throbbing. And so in patients with stroke or spinal cord injury, we end up with this sort of central mechanism for pain. Now, just like in medicine, there are always exceptions to the rules. There are always combinations of mechanisms. And these could involve both an abnormality, so say your pain perception is abnormal, or your pain transmission is abnormal, or your pain modulatory pathways are abnormal. And this can have a great deal in how we perceive pain and how long the pain can last. Now, neuropathic pain has been described as several things: an ache, a throb, a shooting or lancinating pain like somebody stabbing you, a stinging pain, a burning pain, an extra sensitivity. Now, why would it have all these mechanisms? And once again, I'm sure you have patients who ask you, okay, I have this pain in my head. It's been an ache, but lately it feels like somebody's pricking me with something so sharp. Surely I need an imaging. I need another MRI. And you spend the next half hour trying to convince them why they might not need an MRI, because it's just the nature of the pain that has changed. But The mechanism of neuropathic pain involves both the ascending, which is our perception, and the descending pathways, which modulates it. And sometimes when we have nerve damage, we can get a persistent stimulation of the ascending pathways. And this whole thing results in a rewiring of our pain circuits, both anatomically and biochemically, because it's not just the anatomical spinothalamic, it's also which sort of neurotransmitters are released and are they being constantly released. And in this case, we have a lot of sodium channel involvement. So when we have a rewiring of these circuits, we can end up with spontaneous nerve stimulation. So you perceive the pain even without any stimulation. Or you could have autonomic stimulation, if we remember, in patients who've had Bell's palsy, say, because ideally it's a motor phenomenon, but sometimes as they recover, they end up with a persistent post-auricular pain, pain behind the ear, that is just an autonomic sort of hyperstimulation around the area of the facial nerve. It doesn't mean that anything has changed, but to the patient, they were doing better, and then they develop pain, so it must mean something else is wrong. Now, this diagram is supposed to help us remember from our anatomy the perception of pain in red, which, if you remember, was mostly modulated by a dorsal root ganglion at the bottom of your box. So you have the nociceptive fibers, which are usually your C fibers or A delta fibers. And they would go through your dorsal root ganglion. They would decussate and come to the, from the dorsal horn, they'd come anteriorly and travel up from your spinal thalamic tract, from the spine to the thalamus, and then they would be sent outwards towards the cortical fibers, and that is where we perceive the pain from our cortical fibers. Now, this is all well and good, but in order for us to either react or to modulate the pain, so if you touched something hot, we either need to pull our hand back or we need to modulate the pain, then we have descending fibers. And these would travel slightly different pathways, and as you can see, are facilitated by different, I will say, neurotransmitters. They involve sodium channels, they involve, and that's really, that is why we choose certain drugs to modulate these descending pathways, because these decrease our perception of the pain. Now, for the ascending pathways, as you can see, the drugs in red would reduce that ascending pathway and reduce our pain sensitivity. But these would not be useful for long term because it would anticipate that these drugs are being used when you're continuously perceiving the pain from some external stimuli. But we mentioned that there are some auto-stimulations, and so in that case, just using the drugs in the red box might not be useful. We need to also modulate how we perceive the pain or how severe the pain is. And that's why we sometimes tend to combine these drugs. There are lots of different pain theories. Some of them have been described from almost 200 years ago. They're important to read, to understand, but this also helps you explain to your patient why you would need certain drugs that they would consider that you're using for depression, when in fact, you're helping them in terms of their perception of the pain. Sometimes I tend to explain it using the sentence that when you've had pain for more than 2 weeks, it becomes impossible to tell a pain that's a 3 out of 10 from a pain that's a 9 out of 10, because every day feels like a 9 out of 10. And the problem with that is that you're not able to make use of your days, even though you're not out of pain, but you're not able to make use of your days that are 3 out of 10. So what happens is your day becomes a dark day every single day. So I tell them, I'm giving you this drug so that you're able to perceive 3 out of 10s and 4 out of 10s and able to tell the difference between those from 8 out of 10s. And so that on your 3s and 4s, you can actually achieve certain things. Let's talk about some individual pain syndrome, and we'll talk about one of the most common pain syndromes. I know nearly all of us have dealt with diabetics, and so I'll probably start by just asking a few clinical related questions. On your screen now, you see a QR code. If you're able to, I'll ask you to scan it. Dr. Dawn will also put it in the chat box. So in case you can't take a screenshot and scan it with your QR code reader, you can tap on the link and you should get to a screen which allows you to enter a name so that you can participate in the quiz. Now, in the era of data protection, if you don't want to put your real name, that is fine. You can go by Hot Girl or Dark Knight, that's fine. But let's just try these questions. Dr. Dawn, because I'm still on my slideshow, I'll ask you to just tell me how things are going because I can't see the questions or see what the responses are like.
Right. Thanks, Doc. So there's those who are not able to scan the QR because they're using the same device. There is a link that I've put in the chat section. So just click onto that link and then enter your name. All right. And then let me just get to the participants section. Enter your name. And then I'll start the poll. So I'll give you about a minute. Yeah, so all right, Gal, Chella, name, Penina, I can see you. All right, Kito, Moses, Penina. All right, so I'll give us some extra 30 seconds, just allow everybody to be able to join the poll before I put in the first question, the first quiz. So either use the QR code on your screen or click on the link in the chat section. Okay. All right, so I'll do the first question, Doc, if you allow me.
Please do, because I'm blinded to the questions and how people are responding. So please take us through this section.
All right, that's fine. That's fine. So the first question should be on your screen right now. So you have a minute to respond. After which it will automatically close. All right, so the responses are coming in. Right, great. The poll is closing in about 30 seconds. So if you haven't been able to put in your answer, please do so. The question is, a 70-year-old man with painful diabetic neuropathy reports only partial relief on amitriptyline, which is the best evidence-based add-on. All right, 5% is saying that you need to add, that's gone down to 4%, levetiracetam. 6% is saying that you need to add an opioid immediately. 80% is saying that you need to add pregabalin. That's gone to 78%. Somebody has changed their mind. 3% is saying you need to add topiramate. 5% are saying that you need to add clonazepam. So on your screen, or Doc, do you want to say something before I reveal the correct answer?
No, go right ahead.
All right. Okay, all right. So we have 119 votes. That's quite commendable. So the right answer is on your screen. Add pregabalin. So a majority were right. Do we move to the second?
Yes, please.
All right. Sorry. Just a brief of how, right. Judith, you're doing well. Okay. Next. This will take 45 seconds. It's on your screen. Please put in your responses. Okay. Answers are coming in. Read the question carefully. The faster you answer, the more likely you'll be at the top of the list. Typical distribution of what gaze work will look like, Doc. Interesting. All right. It's closing in about 7 seconds. All right. this is almost even distribution, with 49% saying you need to add amitriptyline. So the question is, a 66-year-old woman with diabetic neuropathy has painful feet and insomnia. The poll has closed. She has a history of palpitations and paroxysmal atrial fibrillations. So which medication is safest to start? A majority are saying amitriptyline, nortriptyline, 18% tramadol, 18 are saying duloxetine, and 2%. So the correct answer is on
Sorry,
use.
could you read those out again? 49% said AMI.
49% amitriptyline, 14% nortriptyline,
Right,
18% tramadol,
right,
18 duloxetine,
right.
and 2% topiramate.
Okay, excellent. This will help me with what I need to go through. Excellent. You can
So we do the
review.
last, the correct answer is already on their screens.
Okay.
All right. So we do the last question in this first section, and then Doc can proceed. So the next quiz should be on your screen in 30 seconds. All right, answers are coming in. 8 votes so far, 15, 18 votes, 26 have cast in their vote. It's closing in 8 seconds, so please cast in your vote if you haven't. Put in your correct choice. 88 people have responded. The poll is closing in, it's closed with 110 votes, with also a very classic distribution of responses. So the question is, a 71-year-old man with diabetic neuropathy and chronic kidney disease with an EGFR of 25 mils per minute has partial relief on duloxetine. So what is the best add-on therapy? 29% are saying pregabalin, 41% gabapentin, 7% amitriptyline, 10% NSAIDs, 14% carbamazepine. All right, so the correct answer is on your screen. So the minority are actually correct. Doc, back to you.
Thank you so much. Thank you so much. This is, I'll be dealing with the rationale behind some of those answers, hopefully in the next 2 slides. And we'll go specifically to why those answers were chosen, but thank you so much. So, diabetic neuropathy. How do we manage the pain? Now, as we rightfully know, this is one of the commonest neuropathies. I won't go into what causes it, how it feels. I think that was beyond the scope of this. But when you're a patient who's come in, I think the first thing we need to be aware of is this patient well controlled? Because we do know that they're more likely going to get this peripheral neuropathy if they're not well controlled. So my assumption is that we have done a good job in making sure the patients are controlled, be it by lifestyle, dietary, and medication, right? And then we now need to manage their pain. Now, we do know that when patients are, especially type 2 diabetics, and they are on metformin, the metformin as a drug tends to lower their vitamin B12 level. And that's why generally patients on metformin also end up being put on B12 supplements. However, if you think about all your diabetic patients, or if you're a diabetic yourself, you will notice that you're hardly given B12 alone. And what happens is you're given a combination of B vitamins. So it'll be B1, B6, and probably B12. And that is fine, you know, why buy one when you can buy 6? But the problem with that is that B6 actually has a toxicity. And guess what the toxicity is? Peripheral neuropathy. So we're giving them a drug that they don't really need, and probably in the long term causing a worsening of their sensation. So sometimes what happens is, if your diabetic has been on this combination B vitamin for a long time to supplement rightfully their B12 because they're on metformin, then the right thing to do is probably stop the B vitamins that they don't need take a look at their B12 levels, and if they're not too bad, give them a break from that B12 and manage their peripheral neuropathy. Now, depending on which guidelines you're using, if you're based on the American, if you are leaning towards the British, if you want to like the Canadians more or the Australians, they tend to switch whether either we are starting with a serotonin norepinephrine reuptake inhibitor or a tricyclic. Those two are considered, a SNRI, a tricyclic, or a pentanoid, a gabapentinoid. Those three are usually considered around first line, but also because most of our type 2 diabetics tend to be in the older age groups, we tend to put our tricyclics a little bit lower because of the possibility of cardiac involvement. So this is alluding to our question number 2. That said, we tend to also consider cost because we know that a lot of these drugs will be taken long term. So you don't want to start with the most expensive that's going to be taken long term. So I would say in our setup, we tend to use either pregabalin or gabapentin as the first line. It wouldn't be wrong to include a duloxetine or venlafaxine as an add-on, but sometimes just a single drug is good enough. So there are sometimes you come across lots of combination therapies which have a bit of the gabapentinoid and a bit of the B vitamins, and those make sense in diabetics, but like we said, at some point, those good things in the B vitamins become a poison. The table at the bottom of your current screen shows you the comorbidities that would favor use of certain drugs, because you said those 3 classes of drugs started one at a time are probably going to be useful. But there are some comorbidities that would favor their use, and there were some that would favor avoidance. So let's say you have your diabetic who's also going through anxiety or depression, then the choice of, say, an SNRI would be useful in these patients. But if they have features of sexual dysfunction, and especially men are very sensitive to that, then you might want to reconsider this as well and say maybe that's not the greatest place to start. Likewise, if your patient is having problems sleeping, then it would be a good idea to pick something that will help with that as well, because we do know that their neuropathy tends to feel worse at night. So we want them to be able to get some rest so that they're not awake feeling that pain. And likewise, a tricyclic would be great for that, amitriptyline, nortriptyline. However, we do know that these drugs cause palpitations and are not safe in patients with arrhythmias because they prolong your QT interval. So these are not drugs that I would use in elderly diabetics who've already had, say, AFib and who suffer from palpitations. These are not drugs that I would rush to use. And that is why in question number 2, amitriptyline and nortriptyline wouldn't be good choices. We'd pick something else. And out of that list, duloxetine was probably a good choice. And that's why it was the answer. For our gabapentinoid, really useful, I would call them low-hanging fruit. Great drugs. The beauty is they can also be used in other things like restless legs. And sometimes it's very difficult to tell, is there trouble at night because of the peripheral neuropathy or because they're having restless legs? So these are really useful drugs. And they also help with sleep. So you're hitting 2 areas. However, their downside, yes, they do cause a bit of weight gain, just like the tricyclics. And sometimes they can cause peripheral edema and leave your patient a little dizzy. In elderly patients, it can lead to falls. And we know, especially in elderly patients, falls and frailty are huge, huge red flags that we should be avoiding. So this table sort of helps you choose about what would be a good drug to start with, because they're more or less on the same level. And it would also force you to sort of start with one and slowly build up instead of starting all 3. I know there are a lot of combination formulations, which you might want to get all the benefit of everything at once, but remember, you'll also be picking up all the side effects at once. So sometimes it's good to taper things in, and that way, in case they get intolerable, you're able to dial back on a single drug rather than having to stop your whole combination therapy at once. Once again, I'll mention the importance of things like glycemic control, lifestyle control, foot care, B12, the use of metformin. And sometimes if these drugs aren't enough, then we need to move to topical therapies, capsaicin. They've been thought to be somewhat effective. And as a last resort, there are some centers, maybe not locally, that offer spinal cord modulation to bring down those patients with a lot of severe pain. I will mention that combination therapy usually is more effective than monotherapy, but it helps to slowly build up, because otherwise, like we said, if you had a packet of M&Ms and you eat all of them at once, then you have no more M&Ms. So sometimes if you eat one at a time, then you have more to share out. Okay, so rather than start with all the drugs at once, I would suggest that we go one by one. Now, we remember the last question, which was regarding the 71-year-old who had CKD. It's probably not on this slide, but the gabapentinoids have to be renal dose adjusted. And usually they're adjusted even before you get to CKD 4 and 5. So by the time you're already in CKD 3, we need to adjust the dose. And so in that 71-year-old patient who was already in CKD stage 5, then the gabapentinoids, the pregabalin, the gabapentin would not be great choices. We also know that a drug like duloxetine would probably need to be renal dosed, but that is further on, maybe around stage 5 or 4. And so in that patient, if they don't have cardiac comorbidities, amitriptyline might be a drug that's better tolerated. And that's why that tended to be the drug that you would choose. Like we've said, God usually gives you more, a few more things. He won't just give you, CKD and no cardiac. That's a patient who it's unlikely that they'd have CKD without any cardiac disease. But that's why I didn't put duloxetine there, because it would have been a tough choice with that question. But well done, well done. We'll move on to our next pain syndrome. And in order to just sort of prepare us or get us thinking about it, we'll do a few more questions. Just 2 questions this time.
Right. Thanks, Doc. So a few of us weren't able to tell what the questions were. So I'll again put in the link. You're able to can scan the QR code on your screen or click on the link that is on your screen. So there's a link that's on your screen in the chat section. You can click on that link or scan the QR code. It will bring you to the question section. And I'll give you about 30 seconds before I present the next question. All right, so the next question is on your screen. We have 30 seconds. Two votes already in terms of responses, 11 responses, 16. So the quiz is locking in 7 seconds. So please put in your response. So it's locked with 100 responses so far. 56-year-old woman who presents with sudden severe electric shock-like pain on the right side of her face, triggered by chewing and brushing teeth. Neurological exam is otherwise normal. MRI brain is normal. What is the most appropriate first-line therapy? And you're thinking trigeminal neuralgia. So 32% saying carbamazepine, 25% amitriptyline, 28% gabapentin, 11% baclofen, and 4% tramadol. Doc, is there something you want to say before I reveal the answer?
So like you rightfully said, that description is a trigeminal neuralgia. So it was our round and about way of figuring out which drug would probably be best indicated.
Sure. All right, so the right answer is on your screen. Okay, so majority got it right, Doc.
Excellent.
So the next quiz, and let's try. We had 100 votes, or in terms of responses in this question. Let's try. It's 30 seconds, so you'll do well to be a bit fast. The next question is on your screen. Okay. Sorry, switching between windows. All right. So we have 106 responses out of 367. So maybe I don't know if others are not able to put in their responses, but we hope to make this better in the next quiz. So please try and give us your feedback. That will help us know what Doc will need to put more emphasis on in terms of what she's teaching. All right. So the link, let me just, Doc, give me a few minutes. There are a few issues here. The link is not responding. Time is too short. So I'll increase that time to 1 minute just to allow everyone to read, think, and respond. Okay. The link is not Kennedy Kiptum. I've put up the link yet again. Please try. If you're able to now click the link, or if not, try and use the QR code, then put in a name, whatever name it is, it will bring you to the poll section. So other than the time, anything else that's making anyone not be able to respond in time? Other than the clinical content, which we may not change right now. Just put in give me a feedback in the chat section. In the chat section. Elvis, letting your hand is up. Please just put in your feedback in the chat section. So Doc, allow me increase that time to 60 seconds.
No problem. Are we redoing question 5?
I'll just a minute.
Or do we go with what we already have? And then
let's redo it. So I've already changed the timing to 1 minute, because we haven't revealed the answer yet. So that's done. So I'm relaunching question 5. Okay. Question 5. So allow me to go to just a minute. Question 5. This ones we have done. So we'll go to question 5. Okay. So the question number 5 is on your screen, and the time is 1 minute. So those who are not able to put in their responses, please go ahead. Okay, I can see a bit more responses coming in. 117, much better than what we had. Please put in your response. 127, that's 130. We're doing much better. 133. If you haven't had time to put in your response, please do so. All right, so it's closed. We have 154, much better, almost half have responded. And so a 68-year-old woman has trigeminal neuralgia, controlled on carbamazepine for 3 years. She now develops hyponatremia with a sodium of 124 and dizziness. So what is the most appropriate next step? 7% are saying continue carbamazepine with fluid restriction. 26% is saying switch to oxcarbazepine. 1% microvascular decompression surgery immediately. 5% start IV phenytoin. 61% switch to gabapentin or baclofen. So majority are saying you switch to gabapentin or baclofen. So the correct answer is on your screen. All right. Doc, you can guide whether we...
All right.
Yeah.
So majority chose E.
Yes.
Okay. Microvascular. Okay. Sawa. All right. Thank you so much. All right. So hopefully we will cover this in the next few minutes. Okay. So trigeminal neuralgia. We all remember the anatomy of the trigeminal nerve. We all remember where it came from. We all remember its 3 distributions. In red was V1 of the or the ophthalmic of distribution. Blue was the maxillary, and 3 was the mandibular. What we might not want to remember so well, and don't worry, I won't force us to remember this in depth, was that the ophthalmic had several branches. So what was in red also had several branches: a sensory, a frontal nerve, a lacrimal nerve, a nasociliary. The maxillary also had several branches: the zygomatic, infraorbital, anterior superior alveolar, and the mandibular had several nerves as well. Why this is important is as we approach trigeminal neuralgia, sometimes you have more of one particular division being affected, and more often than not, it's going to be the lower divisions that are affected rather than the higher divisions when we're thinking about the types of trigeminal neuralgia. So what exactly is it? We remember it gives you clinically this stereotyped, intense, sharp, superficial, electric shock like. It's usually a really debilitating facial pain, and it's more often in the lower divisions. And sometimes it even creates spasms at the onset of the pain to the point where the patient cannot chew, cannot eat, cannot brush their teeth. They are miserable. For some reason, it is slightly more in females than in males, and slightly more in a slightly older population. It is unilateral, but God has a sense of humor and can give you bilateral trigeminal neuralgia. And when you see bilateral or switching sides, we need to really think about something like multiple sclerosis. Our triggers could include things like chewing, talking, brushing teeth, just even cold air, smiling, grimacing, touching. It's almost nothing, almost everything that can trigger the pain. And sometimes you also get autonomic features. So apart from the pain, you also get a red eye, a running nose, and then you start wondering, is this part of a headache syndrome? Because there are headaches that can give you this, or is it actually a facial pain? In about half of the people, it can be a continuous pain that doesn't just come in spasms and seems to come especially after you've had some form of dental manipulation. And so a lot of times the dentists end up seeing them first. Now, when we evaluate these patients, we want to first make sure we're not missing something like, say, a herpes zoster or a post-herpetic neuralgia or some form of mechanical injury to the nerve. Like we said, especially when you're doing dental surgery, if you've gone to the top jaw, then you'll be dealing with the maxillary nerve. And if you had to block a nerve in order to do that dental surgery, sometimes it can feel very much like a trigeminal neuralgia. Or if you're on the lower jaw and you needed a buccal block, that can also feel like a trigeminal neuralgia. But when you think about that anatomically, why should your pain be in the maxillary division if you just blocked the lower jaw? So a lot of times the dentists are the poor people who have to deal with it first, and then they end up coming to see you because that pain lasts much longer. Now, if you're able to show that this was some form of trigeminal injury, either mechanical or chemical or thermal, then we call that a neuropathy rather than a neuralgia. But if we are able to see none of this, and that's why I said her examination was normal, her MRI was normal, then we call that a neuralgia rather than a neuropathy. And sometimes we see nothing, but when we look at the brain, we're able to see that the nerve is actually in contact with a blood vessel. And sometimes that contact is actually causing compression. So if it's just touching on the blood vessel but not causing compression, we call that idiopathic, all right? Or if it's entirely normal, just normal, we call it idiopathic. If it's, you see the blood vessel just touching the nerve, one of the nerve roots, but it's not quite compressing, we can call that idiopathic or classic. If you actually have evidence that it's touching the nerve and compressing it, then that's classical, and that's one of those patients who would benefit from some form of microvascular decompression. Sometimes it's not an artery that's compressing the nerve, it's actually a plaque, like in multiple sclerosis, or it's some form of tumor, and we call that secondary trigeminal neuralgia. So as you can see, a neuralgia might be a neuropathy for other reasons. So we could have a post-herpetic neuropathy, right? Or we could have trauma to the nerve, or we could have dental causes, or we could have, like we've said, different types of headaches that present and sound very much like a neuralgia pain. How do we treat? The drug of choice is carbamazepine or its relative oxcarbazepine. Now, in these drugs, either alone or in combination, can give complete or near complete pain relief in a really good, decent amount. But we have to start low and go up because it has lots of side effects. But it's important to know that sometimes just to get that pain under control, we need to go up to really, really high doses, and sometimes even up to 3 times a day. You will remember these drugs have lots of side effects, including drowsiness, dizziness, dry mouth, and all that. And we aim for at least 6 to 8 weeks pain-free before weaning off. So remember, you're first bringing in the drug, slowly titrating up, which can take 6 to 8 weeks, and then aiming for pain-free, not just reduced pain. So a lot of times your question is, how long will I be on this drug? So create that impression that it's going to be a while before we wean off. Humans are humans. They're going to try weaning off the drug. Sometimes that works best. You might find your patient tries weaning off and they're fine. In that case, that's great. But a lot of times they'll wean off and they'll realize that the pain comes right back and they'll get back on it. If it's intolerable, or if, you know, there are too many side effects, they're too drowsy, they get a terrible skin rash, then we can move to gabapentinoids or something like lamotrigine or something like baclofen. So this takes us to our question 5, which was the patient, the 68-year-old who was on carbamazepine, doing really well, but they had a side effect which is often not talked about. Carbamazepine, oxcarbazepine, any drugs that work on your sodium channels, which includes drugs for other diseases like epilepsy, phenytoin, all those can cause a hyponatremia. And that needs to be dealt with. So we can't give it a relative of the same drug. So in that patient who was on carbamazepine, oxcarbazepine would not be a good alternative because it will do the same thing. It works on the same sodium channels. So we need to think about an alternative drug. And this brings us down to the possibility of gabapentin or pregabalin. Not as effective, but certainly an alternative. If that doesn't work, then we can move to microvascular decompression. But as we said, that works if you only have the contact with compression. Otherwise, you're going in to do nothing, and no surgeon wants to go in and get a bad outcome. So we've answered both our MCQs, and hopefully it makes sense. Let's move on to another type of neuropathic pain. So sometimes we have trigeminal pain that is coming from the spinal trigeminal nuclear origin, or that is, like we said, from MS. So you have trigeminal neuropathy from both sides of your face, which would just be ridiculous. Or you have post-stroke pain. It affected your basal ganglia. Now, this could be a facial pain, a head pain, and it could be because of the demyelination, or it could be coming, especially in multiple sclerosis, you see the plaque, and then you get the pain, okay? Or if you have the pain, you're able to look back at the imaging and see the plaque. Now, usually this is a diagnosis of exclusion. So when we're doing our imaging for trigeminal neuralgia, it's a good idea to think about the possibility of MS so that we ask for the right sequences. So since we're interested in vessels, we'll not just ask for an MR of the brain, we'll ask for an MRA. If we're interested in multiple sclerosis, we won't just ask for an MRI of the brain, we'll ask for an MRI of the brain with contrast so that we can possibly pick out the possibility of demyelination as well as vascular contact, and then ask them to focus on the trigeminal nerve. Now, the one from multiple sclerosis would be continuous. It can also be paroxysmal, meaning it's coming and going, but it would be continuous. It might have a lot more. There might be sensory disturbances. It could be on both sides, like we said. So it's really pain that just doesn't listen. Thinking about post-stroke pain, and I'm sure you've probably come across a patient like this. They've had a stroke, and then maybe a year later, they just get pain in the weak side, and they wonder, is this another stroke? Not really. It's just an overstimulation or a rewiring of the circuitry from their basal ganglia where the stroke affected. It's really debilitating, and especially because it comes so far after the stroke, just when they feel like they were getting used to their weakness and they're managing, then they start with pain. So sometimes it can be attributed to a lesion involving the area that was involved in the stroke or projections from the trigeminal nuclei. It's persistent, it's really debilitating, and it can be delayed, like we said. It's very, very debilitating for the patient because they feel like they've done well, and then pain comes in. The intensity can vary. So what is our aim? Our aim is to reduce the CNS activity, and we do this with anticonvulsants or even benzodiazepines, to reduce or enhance, to enhance reuptake of serotonin and noradrenaline. We can use the SNRIs, or to influence adrenal receptors. And sometimes we can also go peripherally or centrally. So we can either do things like deep brain stimulation or transcutaneous nerve stimulation. And I saw a lot of physiotherapy colleagues joining us. And this is an area that I know they know a lot more about. And we usually ask them to help us with this sort of pain management. So it can be really challenging. I know you know this from your patients. And sometimes we need to prepare the patient mentally that this is going to be long-term and they're going to be on these drugs. And that means they're going to have some of these side effects, the drowsiness, the weight gain, the hyponatremia, which might need us to change drugs. So if we're thinking of post-stroke pain, then we use things like our tricyclics or our anti-seizure medications. If you're thinking of multiple sclerosis and it sounds like a neuralgia rather than a neuropathy, carbamazepine would be the drug. Sometimes we have both neuralgic pain and non-neuralgic pain, then a combination would be useful. And if that doesn't work, then we step up and also introduce neuromodulation. My point would be, once again, it won't be likely that one single thing will work alone, all right? So we have some limited evidence on what is going to work very well. And so a lot of times it's trial and error. From the European Federation, tricyclics are their first choice, and then gabapentinoids come in, and then lastly, lamotrigine and opioids. If you're leaning towards the Canadians, then you could start at your gabapentinoids, move on to your opioids as a second line, move on to your cannabinoids, and then move on to drugs like methadone or lacosamide. As you can see, when there's so many choices, it means that people don't really have a clear path. So everyone's trying what could work. There's really a trial and error approach. So you're not wrong, but keep trying. I will bring in the fact that for every drug you put in, you need to give it at least 6 to 8 weeks to kick in before either escalating or before deciding that that drug doesn't work. So you can imagine this is a patient that you'll be seeing every 2 months to adjust doses. So when you have a prescription that says 2 weeks of amitriptyline, then they come in and the next one is 2 weeks of pregabalin, you're not really giving the drugs a fair chance. We'll move on to another important type of, I will say, neuropathic pain. We've all seen the herpes zoster lesions. What do we do when they come in with these post-herpetic? So that is the pain that comes after the lesions have healed. And as you remember, it can be extremely debilitating. and it can persist even beyond 3 months. Same distribution, everything is healed, and now all they have is pain. So once again, we use a stepwise approach. And usually we start, if it's mild pain, then we can even go topical. But a lot of times they won't come to see you if it's mild pain, because they'll have picked these things off a pharmacist. They'll come to you when it's really bad. So once again, stepwise, we can start with the pentanoid. And if there's an inadequate response and we're moving up with the dose, as we said, we're giving it time and moving up with the dose, then we can either add on or switch, if they're intolerable, to a drug like a tricyclic. If there's an inadequate response to either one or to the addition, then we can add anti-epileptics. Like we've said, let's be patient. Let's do it one at a time, because when you put all three at once and nothing's working, you still need to continue them for 6 to 8 weeks, and the patient will still be seeing you every 2 weeks wondering why you're doing nothing. So that way, escalate, give these drugs time to kick in. If there's contraindication or inadequate responses, then you might go to certain types of pain modulation, of which the pain specialists sometimes try injectables. But more often than not, I've found that with appropriate combinations and time and a lot of encouraging the patient, the pain eventually comes down. Fibromyalgia. Oh my goodness. This is one of the most unrewarding things to treat. One, because it's chronic, it's widespread, and it's extremely painful. And it's not just, it's musculoskeletal. It's accompanied by everything else, by fatigue, by sleep problems, by cognitive problems, by somatic and psychiatric depression, anxiety. So it's one of the most unrewarding and draining things to treat. But our job is to do a good job of trying to help these people, because they're already in a hole. Let's provide hope. So the first thing, we don't know what causes it. And that's why it's so frustrating, both for you and for the patient. We don't know what causes it. So with that, we need to provide hope in every aspect, because no single drug is going to work. We have a lot of patient education to do. We need to educate them that this pain is not from one thing, because they will want to do specific tests over and over again. And it's your duty to make sure that these tests are normal, so that we can say it's a diagnosis of exclusion, that this is fibromyalgia. We need to manage their comorbidities. Like we said, there's no way you're going to manage chronic pain without managing the descending circuits, which are modulating circuits. So the mood, the sleep, the musculoskeletal areas, and this involves physiotherapy, heat therapy, cold therapy if necessary, exercise, sleep programs, sleep hygiene, and lastly, medications. So the medications is just a small part. They need to do a lot on their own. They need to be educated. And like we've said, it's a bit of a choice. The tricyclics, the SNRIs, the anticonvulsants. And if all else fails, then we bring in the rheumatologists, the psychiatrists, the pain therapists, the psychotherapists, and multidisciplinary programs. It's a very, very draining thing to treat and to have. So let's do our best to help these patients and make them realize that they are not alone, and that there won't be a single thing. Everyone is looking for a magic pill. There is no magic pill. It's a combination of things. So sometimes I tell them, each of these things you're doing is contributing 5% less pain. Okay, so think of it like if you're putting money aside for your future. This one is bringing you 5 bob, this one is bringing you 10 bob. So all these things, we do them together. We don't say, I'm going to take the drugs and not exercise. We say, I'm going to exercise, I'm going to take the drugs, I'm going to work on my sleep, I'm going to see my therapist. And all these things eventually add up. Lastly, I'll talk about the complex regional pain syndrome. It's mysterious. I don't know if you've ever come across these patients. These are patients who, for no reason, will have a mysterious chronic pain in a particular region. I remember a patient of mine had it on one upper limb, and that patient was in so much pain they couldn't use that limb. It was their dominant limb, it's the right limb, till you start wondering, hii ni urogi ama huyu hataki kufanya kazi? But really, it's painful, and pain cannot be seen. It's disproportionate to any known cause. you can't find any trauma, you do the nerve tests, you do the imaging of the structures, everything looks normal. But when you look at that limb, it's actually swollen. So that's the thing. And it's more distal. It has abnormal sensory when you test it. But when you actually subject them to, say, a nerve test, it's normal. But you might find that that limb is swollen and is dry and looks different. So for all practical purposes, there's something wrong there, but nothing shows up. So how do we manage it? It's a bit like fibromyalgia. We're aiming to restore function. We're aiming to decrease the pain, the disability, to improve their quality of life. We're not just going straight to drugs. We want to educate these patients. We want to bring in the physical therapy, the occupational, the psychosocial approach. Lastly, we want to bring in drugs that will be used chronically. So NSAIDs don't really help if you're thinking chronic pain. So eventually we move to the gabapentinoids, the tricyclics. Sometimes because of disuse, you also have some element of bone disease. And so sometimes we bring in bisphosphonates, and you might find that topical things might help as well. So that said, there's one pain syndrome I haven't talked about, but we will get to it in just a bit. This was supposed to just guide us through what we've talked about. It's a very busy slide, so I will guide you through it. I would say for any chronic non-cancer pain, then we start with lifestyle measures as we bring in their pharmacological measures, because I don't think thinking of just drugs alone will be useful. So we must bring in things like exercise. We must bring in physical therapy, let them understand what works for them. Is it ice therapy? Is it heat therapy? The physiotherapist, I'm so glad you're here because you probably have a lot more experience with this. Sleep hygiene, they can't be up all night and then sleeping during the day and eating wrong and expect their pain to disappear. Behavioral therapies, cognitive behavioral therapy, they sometimes need a therapist to help them manage the other things that are contributing to daily pain. Acupuncture has been thought to be very useful, and if the pain continues, then we have a chance to bring in pharmacology. And like we've said, if it's an active or very acute pain, then NSAIDs would help. But if it's a neuropathic pain, we've already brought out 3 major groups of drugs that are very useful. Trigeminal, we go with the carbamazepine. Any other, we have either SNRIs, or gabapentinoids and pregabalins, or anticonvulsants in other areas. There's a lot of talk about cannabinoids. We don't have enough evidence to say that they are guideline directed, but we have a lot of anecdotal reports of patients having improved pain, especially in patients who have diseases like epilepsy or multiple sclerosis associated pain. But I won't say we have enough in our guidelines or enough studies to say that they are part of our guideline directed therapy. So I would say they would be useful anecdotally, but I wouldn't put them high up there. So let's look at our last questions. I promise you this is my last slide.
Right. So we'll have as many participate in this last quiz. So I'll again put the link in the chat section. Okay. So you can either use the link or you can scan the QR code on your screen. All right. And then we'll get to the question section. All right. So the last question. So we have about the participants who are still joining. So we'll give them a few minutes. So once you click on the link, please put in your name. Doesn't have to be your real name, but just a name for the sake of this quiz. So we are currently at about 370, 80. We hope to have, more than 200 responses in this last question. So please try and give us some feedback. So keep joining. All right. So I'll move quickly through the very first question that we did. For those who are not there, the correct answer is on your screen. So these are the questions we have done. This was our second question. And I'll move to the last question, which is of interest to us, because this is already done. Okay. So we go to, that was our third question. This was our fourth, which was also pretty much well done. This was the fifth with about 154 votes. Well done as well. The sixth question was this, which was the second last.
So that's
And
the one we should be on now.
Yes. Yes. So we have two questions, and it is on your screen. Just a minute. So I put it up again. So it should be on your screen right now. So the poll will close in about 20 seconds. So the poll is closed. 55-year-old man with alcoholic neuropathy presents with painful paresthesias and weakness in both legs, which treatment provides the greatest long-term benefit. So 81% saying thiamine supplementation and alcohol abstinence, 13% high-dose pregabalin, 3% oral corticosteroids. We have 149 votes. 2 are saying IV immunoglobulin, and nobody thought to mention surgical decompression. So majority thiamine supplementation. So the correct answer is on your screen. So the majority were right. Doc, do we move to the next?
Yes, please. I think we just have one more.
Yes, the last question is on your screen right now. Keep your responses coming. 130 have responded. Okay. All right, so the poll is locked. So we have 156 votes, quite commendable. So the question is, a 58-year-old man with alcoholic neuropathy has persistent neuropathic pain despite thiamine replacement and alcohol abstinence. which drug is the most appropriate to control symptoms. So about 30% say carbamazepine, 48%, almost half, pregabalin, 4% acetaminophen, and 18% diazepam. So about
Was there
half.
an E?
There's an E, sorry, 1% IV steroids.
Okay.
Yeah. So about half, say pregabalin. So the correct answer is on your screen. That's what the majority got as the correct answer. Back to you, Doc.
Thank you so much. So, as you've noticed, I've asked two questions about actually what I would call the second most common reason for peripheral neuropathy, painful peripheral neuropathy. The first would be diabetes, the second would be alcohol. And the reason I did this was I didn't have the chance to put it in my presentation, but I thought I wouldn't be doing justice without mentioning two things about it. One, it's the second most common reason. So if you're taking a history, start with uko na ugonjwa wa sukari, pombe ni ngapi unakunywa? Because if you ask unakunywa pombe, even me, I'll say I don't. Okay, so create the option for people to drink and give them an option so that they just tell you how much they drink. Okay. So the next thing I wanted to bring in is because of the pathogenesis of how it causes the neuropathy, as long as you still have minimal amounts of alcohol being ingested, your neuropathy is going to continue. So therefore, we don't say reduce your alcohol consumption, it actually needs to cease. Because even tiny amounts, if you're predisposed to alcohol-induced peripheral neuropathy, and as you remember, not everyone is, because otherwise we'd have a whole lot of Kenyans who EABL needs to worry about, right? So once you have the genetic predisposition, even tiny amounts of alcohol will cause your neuropathy to persist. So the aim is, apart from replacing your thiamine, we need to cease the alcohol. And so I'm so glad that 81% of you overwhelmingly said that thiamine and cessation is important. Now, if that doesn't work, because very often it might not, and then they look at you like, Gwenda, you even told me to stop my booze and nothing has happened, then we now bring in the drugs. Now, the truth is, usually we bring in the drugs as we are hoping that they'll stop the alcohol. And sometimes these things are happening concurrently. So every time you see them, you're assessing whether they have stopped so that they understand that cessation is not an option. It has to happen. That said, I want to thank you all so much for paying attention, for joining. I am very happy to answer questions. I will be guided by Eliash on what to or how to approach them. Thank you all.
All right. Thanks so much, Doc. Thanks, Dr. Our attention is now drawn, if you're able to see, from the Q&A section of the Zoom part. We'll start from the very first one. Top of the list, Frida Washira. Frida is asking that she has a 30-year-old patient who presents with fits and emotional lability, a brain MRI revealed temporal lobe sclerosis, bilateral non-specific white matter hyperintensities, and brain atrophy. This patient was put on Tegretol, CR 400 BD, and pregabalin 150 nocte. The fits and emotional ability have significantly reduced, but he recently reported getting electric-like sensations on his limbs. So what could be the reason for this, and what is the best course of action?
Okay, so they have electric-like sensation. I was trying to look for the question, but I think I'm too far off, so I can't read it. I'm just going with what time was the question? What time was that question posted? So I can go by time.
Look at the QA section. Don't look at the chat. There's a QA
chat.
section.
Okay. Sorry. Where is my QA?
Question answer section,
Yes.
and the
Okay,
first section question from Frida Wajira.
Right. Excellent. So, fifth, emotional ability significantly reduced, an electrolyte sensation on their limbs. 32-year-old. Okay. So, thinking through this, I don't see a particular reason related to the fits that they should have these electric-like sensation in their limbs. And so I'm thinking, okay, for some reason, they sound like they have, when we have lancinating limb pain, it is more likely radicular rather than peripheral neuropathy. And what that means is it's more likely coming from a nerve root closer to their back rather than coming from a peripheral like neuropathy like you get in diabetes. So I would probably start by just sort of getting a history. Do they have back pain? Does it ever lancinate down one particular limb? And that way I'd be able to try and figure out whether I need to image their back or not. In the meantime, they're on something like pregabalin that should certainly help with this. And if that isn't working, we have the option of either going up with the dose if it's tolerable, or combining it with something like duloxetine to see if it would help. I would also, like I said, image the back if after examining and making sure that the modalities of sensation are normal before I image.
All right. Thanks, Doc. So I'll give you time to look at the questions. There are about 10 or so.
All right.
So read through. In the meantime, our colleagues and practitioners, we're going to briefly speak about for 2 minutes the sponsor of this webinar. We'll have a 2 minutes, actually a 1 minute presentation as Doc reads and scans through the questions, after which she'll be able to respond to the 13 questions. So I'll just put up my screen. Universal Corporation Limited has been our partner in this and is presenting to us a solution. Let me know if my screen is visible. Okay. All right, so these are your questions. So just a brief on the company that's partnering with us. The audio may not be very clear. Information is founded by Okay, sorry for that. It's not, let me see. Sorry for that. Is it audible? Is the video, Dr. Judith, are you able?
We can't hear.
But you can
And
see.
we just see the first slide. We don't see the video.
You're projecting the visual aid PDF instead of the video.
Meanwhile, Doctor, if it is taking time, shall we go to the next question from Jerry Kamvere?
All right. So Jerry is saying you have a right hand, 3 fingers. I don't know, I'm assuming it's pain. You use a crutch on your right side. It's more than 20 years. When you describe the distribution of your pain, that sounds like a carpal tunnel and could be related to the pain. So my advice would be, instead of just taking medication, let's confirm if it's a carpal tunnel so that it can be dealt with in the way that we deal with carpal tunnels, which is not just medication, but sometimes we need decompressive surgery. I think this ties in with a question asked lower down. I'll scroll down to where Cotieno at 820 Clue asks, first line for carpal tunnel syndrome, 46-year-old female who does laundry job. So the first line is, one, we want to confirm it, and we do that with the nerve conduction test. So when we confirm it, we can group it into whether it's mild, moderate, or severe. Because if it's mild or moderate, we might get away with just splinting of the wrist at night with something for pain. If it's moderate to severe, we might need steroid injections, and sometimes we might need decompression. So that would cover those two. Now, I'll move to the third question, which was by Frida. So you have a patient with trigeminal neuralgia, and this is a very common thing. Trigeminal neuralgia on the left, MRI confirms contact on the right. Left side is normal. Medical management has been ineffective. Should we consider surgical, and where would it be done? So when you think about it, she has trigeminal neuralgia on the left, but her contact is on the right. So that means the right is giving her no trouble. Okay, so what you found is an incidental finding. So this is not a patient who would be a great candidate for surgical decompression. My advice, because the left has no evidence of contact, I would optimize her medical management. And this would probably mean increasing her doses as tolerable, combining treatment, and a lot of psychosocial support so that she's aware that this is going to be long term. So I wouldn't go, I don't think any surgeon wants to go in and operate on the wrong hand, so to speak, okay? Joanne talks about pain. Her mom has pain on the left upper limb, burning, periods of numbness and heaviness, especially at night, relieved by pressing the limb tightly, involving tips of the fingers. So that to me could be one of two things. If she's if she's not diabetic, but she is hypertensive and she has this pain, I am concerned about, is it a radicular pain arising from her cervical spine, of which an examination accompanied with imaging would be useful. Or if she is getting this that goes to the tips of the fingers, are there changes in color to the fingers? Because I'd be worried about a vascular pain. So those are my areas that I'm worried about, and they'd be handled in different ways. My advice would be, first of all, please let her be seen so that this examination can be done and the appropriate investigations ordered. What is the place of physiotherapy in the management of neuropathic pain, especially diabetic and trigeminal? Now, as I said, this is a multidisciplinary approach, and patients with diabetic neuropathy, because pain is just one of the things, remember there's nerve damage, so these patients also get weak, and so these patients will eventually benefit greatly from both physiotherapy and occupational therapy. It might not do a great deal in terms of pain management alone, but they might also be aided with things like TENS or heat therapy or ice therapy to help. And trigeminal neuralgia, like we said, if the medical management isn't working, sometimes electrical stimulation can help as well. So there's a huge role that the physiotherapist comes in with. There's evidence that pregabalin, carbamazepine, gabapentin exacerbate dementia. So there is evidence that any anti-seizure medication will affect memory because of its sedative effects. So what we're saying is, yes, that can be a problem in patients with dementia. So how do we deal with it? Well, unfortunately, if they have one of these neuropathic pain syndromes, then we know that these drugs work. So my advice would probably start low dose, guide the family, because the patient might not know that it's getting worse if they truly have dementia. If they just have forgetfulness, then they will notice it, and just let them know that it is the drug, and as their pain gets better, hopefully we can bring down the drugs. Now, if it's completely intolerable, then we try one or the other rather than a combination of all three. Jack is mentioning they have a client, pain on the lateral side of the leg, starts from the hip. It could be lots of things. I would think in terms of, is it originating from the back? Is it originating from the hip? And so I think a proper assessment of this patient would help elucidate that, rather than me guessing that it's originating from the back, when in fact it might be a hip pain, which we'd handle quite differently. A 14-year-old, he's had DVT of the lower limb for 1 year, lots of pain, 8 out of 10, even on light touch. So if this DVT is no longer an issue, this could be some form of complex regional pain that follows something like a DVT. I would get them assessed, make sure they've been examined, find out if there are any sensory disturbances. If it follows a dermatomal pattern, then we'd think, okay, is this radicular? If it doesn't follow a dermatomal pattern and seems to have like a strict glove or stocking distribution on one limb, that could be some form of complex regional pain. And like we've said, we'd still need to test, because that's a diagnosis of exclusion. And then we'd be able to bring in all those different types of drugs individually. He's 14 years old. So remember, we've said these drugs can all cause some form of memory problems. You don't want to be giving him, and he's sitting a major exam and he can't remember anything. So we'd probably want to be sure of what we're dealing with before we give them the drugs. Reduce the pill burden. This is from Wilson. We have a combination pill in the market, There's several combination pills, but you don't come across gabapentinoids and NSAIDs because, like we've said, NSAIDs are used in acute pain, and so they're short-term drugs. We wouldn't want to give a patient long-term NSAIDs for neuropathic pain. I know the rheumatologists do give sort of, acute medications long-term, but tend to sort of give them drugs that are either COX-2 inhibitors, and there's always a fight with the nephrologists because of the issues that it brings with the kidneys. So yes, there are lots of combination pills. There are gabapentinoids with the B vitamins. There are pentinoids. I haven't come across them with opioids, but there probably are some in the making. When you have a confirmed neuropraxia, neurotmesis, what's the best path? Which is the best treatment? I think our principles remain the same. Pregabalin and gabapentin are not effective for pain at maximal doses. Remember, those are one type of drug working in one way, which is the GABA inhibitors. So that's why we think of combination. The patient is also on sertraline. For PMDD, I'm assuming some type of major depressive disorder. That's great, but we need to also give them something else that would help with pain. Now, as you notice, sertraline wasn't really on the list of how it would modulate pain. So we need to probably talk in conjunction with the psychiatrist whether a drug like duloxetine or venlafaxine might be more useful for these patients, because it would work in both ways. A young girl with chronic headache over 2 months, tried to change spectacles, uses, thought was a problem, normal pain relief drugs not helping, she's eating well, drinking water. So this is more of a headache disorder. I think it's a little beyond our topic today. I would say this young girl needs to be reviewed so that we can get a proper headache history for this patient. No back pain, but the shocks, I think this is the same person. Maybe not. So I've dealt with Cotianos. Is there a difference between pregabalin, gabapentin in terms of efficacy and side effects? Now, ideally, they're touted. One came before the other. Gabapentin was more of the precursor in terms of what it was brought in. So pregabalin was supposed to be the new and improved version of that. And so it's thought that pregabalin would offer slightly less sedation. But what I've found from patients, and we're always humbled by our patients, we think we know and then they teach us. Sometimes when patients are getting unusual side effects from one group of drugs, I find that switching them to another in terms of the gabapentinoid gives them better. So say they were getting overly sedated on pregabalin. I've found that if I slowly switch them to gabapentin, they are less sedated. And that I can't explain that because those drugs work in the same way. In terms of efficacy and side effects, it's thought that pregabalin should be less sedating. It's thought that there should be less weight gain. But basically, they are more or less one or the same drug. How do you manage Sunkton sooner? How often do you encounter them in clinical practice? Well, managing them, these are what we'd call drugs that are exclusively responsive to indomethacin. And indomethacin is an NSAID, a very potent one. So we need to be very sure, because like we've said, indomethacin being a potent NSAID will give you all the side effects, especially gastric. So how often do I encounter them? Quite rare. I honestly can probably think of 2 patients in a long time that I've ever been comfortable saying this is a SUNCT or a SUNA. Now, I will mention that a lot of patients with migraine tend to get what we call primary stabbing headaches, which can sound a bit like a SUNCT or a SUNA. All right, Frederick, a 52-year-old woman presents with right upper limb neuropathy, disturbed sleep, numbness and pain, inability to use the same limb. She's also immunosuppressed on care for over 10 years. Pain doesn't subside with NSAIDs or pregabalin. She now even presents with shoulder subluxation. So how can we manage? For me, the question is, what is this? I mean, if we're subluxing, is this some form of drug-induced bone disease? And I worry about if she's immunosuppressed on a drug like previously TLD, then she might have some form of bone disease, which might have contributed to her subluxation. So for me, rather than how would we manage the pain, I would say let's try and figure out what this is so that we can manage her in totality. But for now, NSAIDs might not be the greatest way to go because she's going to get all the side effects with that. I'd probably be using more of the immunomodulatory drugs. So pregabalin, I'd combine it with something else like duloxetine, if need be, maybe an opioid just to manage that level of pain. Remember, opioids are used short term because of the tendency for addiction. 38-year-old male, this is from Arsene, with sudden onset burning pain of the left hand concerning the ring and small fingers, reduced mobility of the fingers, pregabalin, physiotherapy without improvement. My advice, that distribution sounds very ulnar, so I'd make sure that we're not hiding some form of ulnar nerve compression either at the elbow, which is the commonest site, or at the wrist. So I would get them assessed and I would get a nerve conduction done. And if it is some form of ulnar neuropathy, then we might need decompression to help with that. Would I recommend absolute alcohol nerve blocks for trigeminal neuralgia? I would not. That's not really what I would recommend. But I feel like we have enough evidence-based guidelines on how to manage trigeminal neuralgia. And if those aren't working, we have microvascular decompression. So unless we've done a stepwise and none of these seem to have worked, then I bring in the pain specialists who give me their idea of what would be a good thing to add in a safe way. I feel, there's one more. I have a diabetic patient with a history of uncontrolled diabetes, fecal incontinence, peripheral neuropathy, no sensory level, burning pains, lower limbs, unable to walk. What can be done aside from sugar control, management of the neuropathy? We're thinking of autonomic. So absolutely. I mean, considering they have fecal incontinence, they have no sensory level, but they have burning in the lower limbs. I feel like we're dealing with a possibility of 3 things. We're dealing with the peripheral neuropathy, which is giving them the burning pain. We're dealing with a possible autonomic neuropathy or myelopathy, and especially if this is an elderly patient, they might still have a myelopathy that's arising from some form of compression. Either maybe they have spondylosis, which is now pushing on their spinal cord. And so sugar control, that's fine, but this patient needs to be examined, because if their reflexes or if they have an upgoing plantar, then we're at the spinal cord. If they don't have an upgoing plantar, then we're at the peripheral nerves, and this is autonomic. So in that case, we manage their autonomic symptoms as best as we can. We do lots of lifestyle things. If they do need diapers, like we've said, we might not be able to reverse, but we're trying to give them some form of dignity and make them less have less pain. But right now I'm torn between, is this really an autonomic, or is this probably some form of spondylotic myelopathy? So I feel that was the last, I think the last question.
There are about two more. There are about two more,
Alright.
but you'll crown with those two.
Okay.
They are in the chat section. They're not in the Q&A section. So the last two
Alright.
questions, can be looking at them as we bring a solution to what Doc has just done a presentation on. So Universal Corporation Limited is offering a solution in terms of products that we have talked about. So there's a product by the name Nerve Cap. So it's a capsule for the nerves. That's pregabalin, available in both strengths, 75 milligrams and 150 milligrams. So for your patients who have diabetic neuropathy, trigeminal neuralgia, and the neuropathic pains that we have talked about, that is an option that you have, and you're sure that that quality will be transferred to your patients in terms of relief. The other option that you have from UCL, which is our partner today, is a gabapentin, which is part of the gabapentinoids called Neuroba. All right. So if you're torn between doing a pregabalin or a gabapentin, you have both options. So Nerve Cap for your patients you'll want to put on pregabalin, Neuroba for the patients you'll want to put on gabapentin. And just so that your trigeminal neuralgia is fully covered, there is a carbamazepine, okay, that's available in the form of Neurotrol as a brand, which has been in the market for over 25 years now. So these are the three products that have sponsored our webinar today. So Neurotrol, which is a carbamazepine. So when you're prescribing your carbamazepines to your patients, please remember there's a carbamazepine that's of matched quality, which is in the brand of Neurotrol, and a gabapentin in the brand of Neuroba, and lastly a pregabalin in the brand of Nerve Cap. So Doc, you can complete with those two questions, and then we can bring this to a close.
All right, thank you. I'm seeing now that there was a section where I was not audible. I apologize, I had no idea. I have trouble multitasking, so I was doing one job, even if I couldn't be heard. So I'll start from the bottom and go up. So it's a bottom-up approach. How can lateral epicondylitis be managed? I wonder if that is my question or it belongs to the surgeon, because it sounds like something that is inflamed on a bony prominence. And so I would probably get the surgical input. I really don't know how to answer that, and unless there's something I'm not getting. So James Polly, that I can't help with. I'm going to go to Joy's question. I have a diabetic patient with fecal incontinence, inability to walk, paresthesia on the lower limbs. Could the presentation lie towards autonomic neuropathy? And what do we do aside from sugar control? You might have moved it to the Q&A because I feel like I answered a very similar question. I worry about fecal incontinence in a patient with the lower limb weakness or pain, and I'd want to make sure we are not hiding a spinal cord lesion. That said, apart from sugar control, I would make sure that the nerve conduction test is done. But really, I'm leaning towards this being a myelopathy, so we need to examine and make sure we're not hiding some form of increased reflexes. And remember, this being a diabetic, so even a present reflex would be higher than what we expect. So I would consider that increased, even if the reflex is what we would call normal. In a diabetic, that would be increased, and so I'd go with their plantar responses. What should be done to those patients whose NCESs, this is from Lewis, have revealed that there's no sensation and no signals, but the burning sensation disturbs? So when you say no sensation and no signals, I'm assuming you mean like they have flat lines. So that would be a severe peripheral neuropathy if that's on the nerve conduction. And so really we'd be managing that pain with our escalating doses of the different types of drugs that start with the pentanoid, move on maybe to the tricyclic, and then eventually bring in something like an SNRI, either duloxetine or venlafaxine, if it's tolerable, and make sure that we're not, stopping their heart, so to speak. I hope those are all the questions.
Yeah. All right. I see other questions are not in line with what Doc is answering, but there are quite a number asking about the CPD points. So, 3 CPD points will be awarded for those who attended more than 30 minutes of course, of this webinar. And if you did put in your registration number, that should be automatic. So, Peter, there are questions that I think you'll help us respond to in terms of the recordings. For those who are not able to register who are not able to put in their registration numbers, how do they access the certificates and all that?
So for CPD, I think if you register with the KMPD's registration number, it's quite automatic. We'll update your ICPD account automatically. But after the webinar, again, an email will be sent 2 days after, just a follow-up for those who attended, those who didn't attend. From there, you can reply if you've not received your CPD points. And from there too, you will get a link to the recording of this webinar, which will be available on our YouTube page. So I think that's it. How will you get CPD points and certificate? I think, yeah, when the email comes, I think if you need a certificate of attendance, you could reply and you could avail one for you. Yeah.
All right. Thank you so much. Thank you so much for finding time to be part of this webinar. Thank you for your participation. Thank you, Dr. Judith, for your precise and quite engaging discussion and presentation. Thank you, KMA, for hosting us. Thank you for granting us this platform. Thank you, UCL, for sponsoring this webinar. And thank you for the 3 products that you're offering us this evening. So the take home is on top of what Doc has talked about. When you think of carbamazepine, think of Neurotro. When you think pregabalin, think Navcap. And when you think gabapentin, think Neuroba. All right. Thank you so much. And I want to wish you a very fruitful evening till we meet again when we can't avoid it. Have a lovely evening and good night.
Thank you all. Thank you, Dr. Dom.
From Kenya Medical Association, thank you for attending, and great to have this partnership with this UCL. Looking for more in the future. Thank you.
Thank you.